The topic of lecture is local anesthesia in therapeutic dentistry. The aim of this lecture to focus on anesthetic techniques that are used during treatment of caries and endodontitis. Lecture outlines definition to the term pain, definition of local anesthesia, nerve trigeminal anatomy, techniques used in therapeutic dentistry, armamentarium that is used for local anesthesia, needles, solutions, vasoconstrictors, complications that can arise during local anesthesia. And the foreword to this lecture is quotation from the John Milton Paradise Lost. Pain is a perfect misery, the worst of evils, and excessive. Overturns all patients. Pain and dentistry are often synonymous in the minds of patients, especially those with poor dentition due to multiple extractions. Periodontal disease requiring surgery of symptomatic teeth requiring endodontic therapy. Research has shown that the fear of pain associated with dentistry is closely associated with intraoral administration of local anesthetics, which is the most common method for blocking pain during dental procedures. So what is pain? It is not a simple sensation, but rather a complex neurobehavioral event involving at least two components. First is an individual's discernment or perception of the stimulation of specialized nerve endings designed to transmit information concerning potential or actual tissue damage, nociception. Second is the individual's reaction to this perceived sensation, pain behavior. This is any behavior, physical or emotional, that follows pain perception. Dental practitioners before the procedure identify a good anesthetic as one that allows them to focus solely on operative procedures without distractions from pain-induced patient movement. In no other area of dentistry is the management of pain of greater importance than in endodontics. All too often, the patient in need of endodontic therapy has endured a prolonged period of ever-increasing discomfort before seeking dental care. The reasons for this discomfort are diverse. However, there is one simple explanation in the overwhelming majority of these patients. They are scared. They are afraid of dentistry, which might be the reason for their dental problems in the first place. They are frightened of root canal treatment because of the common perception that it hurts, and they are often terrified at the thought of receiving local anesthetics. So, definition of local anesthesia. Local anesthetics provide temporary loss of sensation to a particular area of the mouth so that the patient will not feel pain. Local anesthesia forms the major part of pain control techniques in dentistry. The prevention and elimination of pain during dental treatment has benefited patients, their doctors, and dental hygienists, enabling the dental profession to make tremendous therapeutic advances that would otherwise have been impossible. And we come across to another part of the lecture that deals with relevant anatomy and nerve supply of the oral region. Management of pain in dentistry requires knowledge about the trigeminal nerve anatomy. It is the largest of the cranial nerves and has three major divisions: ophthalmic, maxillary, and mandibular. In order to anesthetize the teeth and oral mucosa for delivery of dental care, the dental hygienist or therapist needs to be able to select and anesthetize the sensory nerve supply. This is limited to two branches of the trigeminal nerve, for example, maxillary and mandibular divisions of the fifth cranial nerve. To perform local analgesia, dentist must have detailed understanding of the head and neck anatomy to maximize proper administration and minimize complications. Anatomy of maxillary division. The maxillary nerve leaves the cranium through foramen rotundum and enters the pterygopalatine fossa, where it subdivides into three main branches: zygomatic nerve, pterygopalatine nerve, and infraorbital nerve. And by the way, here you can see three subdivisions of nerve trigeminal: nerve ophthalmic, maxillary nerve, and mandibular nerve. And here we have foramen rotundum. Zygomatic nerve enters the orbit through the inferior orbital fissure to supply sensory fibers to the zygomatic area of the face. The pterygopalatine ganglion gives rise to the pterygopalatine nerves: mesopalatine, the greater palatine, and the lesser palatine nerve. They supply the sensory fibers to the palatal mucosa of the hard palate and palatal gingiva. The nasopalatine nerve passes through the incisive foramen to supply the anterior region, and the greater palatine nerve passes through the greater palatine foramen to supply the posterior premolar and molar regions. The lesser palatine nerve passes through the lesser palatine foramen to supply the soft palate. The infraorbital nerve enters the orbit through the inferior orbital fissure and passes along the infraorbital canal, from where it finally emerges onto the face through the infraorbital foramen to supply the lower eyelid, the site of the nose, and the upper lip. The infraorbital nerve gives off the superior alveolar nerve branches, and these are the posterior superior alveolar nerve, the middle superior alveolar nerve, and the anterior superior alveolar nerve. The posterior superior alveolar nerve, it is a branch given off just before the infraorbital nerve enters the canal. It passes downward onto the posterior surface of the maxilla and enters very small canals that run above the tooth roots to supply sensory fibers to the maxillary third and second molar teeth and the distal buccal and palatal roots of the maxillary first molar. This nerve also supplies sensory fibers to the adjacent buccal, gingiva, and maxillary sinus. The middle superior alveolar nerves, not always present. When it is, it arises from the infraorbital nerve within the infraorbital canal. It passes down the wall of the maxillary sinus to supply sensory fibers to the mesiopalatal root of the maxillary first molar and the first and second premolar teeth. This nerve also supplies sensory fibers to the adjacent buccal, gingiva, and maxillary sinus. The anterior superior alveolar nerve. This arises from the infraorbital nerve just before it emerges through the infraorbital foramen. It passes downwards inside the maxillary antrum. It supplies sensory fibers to the maxillary central and lateral incisor and canine teeth and to the adjacent labial gingiva. It also supplies the maxillary sinus. The branches of the superior dental nerves form a plexus above the apices of the maxillary teeth. Mandibular division. The mandibular division is the largest division of the nerve trigeminal. It contains both motor and sensory fibers. It leaves the cranium through the foramen ovale and enters the infratemporal fossa, deep to the lateral pterygoid muscle, where it gives off the following branches. So, nerves to the muscles of mastication. These branches supply motor fibers to the masseter, temporalis, and lateral pterygoid muscle. Buccal nerve, long buccal. These nerves supply sensory fibers to the mucosa and skin of the cheek and the buccal gingiva of the lower molar teeth. Auriculotemporal nerve. This branch supplies sensory fibers to the temporomandibular joint, the skin of the outer ear and temporal area. Lingual nerve. This is a branch that supplies sensory fibers to the lingual gingiva of all the lower teeth, the anterior 2/3 of the tongue, and the floor of the mouth. The chorda tympani branch of the facial nerve joins the lingual nerve, providing special taste fibers to the anterior 2/3 of the tongue. It also carries parasympathetic fibers to the submandibular ganglia to supply the submandibular and sublingual salivary glands. Inferior dental alveolar nerve. This nerve enters the inferior dental canal through the mandibular foramen. Just before it enters, it gives off the mylohyoid nerve that supplies motor fibers to the mylohyoid muscle and the anterior belly of the digastric. Within the inferior dental canal, the inferior dental nerve gives off sensory fibers to the mandibular molars and premolars. At the mental foramen area, the inferior dental nerve branches into the mental and incisive branch. The mental branch passes through the mental foramen to supply sensory fibers to the labial gingiva of mandibular anterior teeth, fossa, and skin of the lower lip and chin. The incisive branch continues in the inferior dental canal to supply sensory fibers to the mandibular anterior teeth. And here you have the anatomy of mandibular nerve. Here we have the foramen ovale through which it enters into the pterygopalatine fossa. And then we have three branches. We have masseteric branch, deep temporal nerve that give the branch buccal nerve, nerve to the medial pterygoid that supplies sensor tympani and tensor palati, nerve to the lateral pterygoid. We have here lingual nerve that give branch chorda tympani that supplies innervation to auricle to the meatus acousticus externus, and here we have inferior alveolar nerve that enters into the mandibular jawbone through mandibular foramen, and here we have branches, inferior dental nerves and mental foramen, through which a mental nerve enters, come out on the face skeletal. So methods of application of local analgesic agents in dentistry. In therapeutic dentistry for treatment of caries and its complication, pulpitis and apical periodontitis, it is advocated to use infiltration analgesia for maxillar teeth and regional block of inferior alveolar nerve for mandible teeth. The methods that are currently available for delivering local dental analgesia are topical, intrapapillary, intraosseous, intraligamentary, subepithelial, infiltration, and nerve block. Topical analgesia. It is injections of local anesthetics usually are painful. That's why topical analgesia can be advocated to prevent painful sensation while injecting of the needle. And we have such definition of topical analgesia. It is defined as a superficial loss of sensation in conjunctiva, mucous membranes, or skin that is produced by direct application of local anesthetic solutions, ointments, gels, or sprays. So injections of local anesthetics are painful and it can worsen needle anxiety and it can cause tissue edema, which distorts the surgical site. Topical anesthetics are used to reduce the sensation of needle penetration prior to local infiltration or to reduce the sensation of gum mucosa when dental calculus is going to be removed. A variety of presentations for topical anesthetic use is available, and it includes aerosols, ointments, gels, lozenges, tablets, pastes, powders, solutions, or patches. The most widespread is aerosols and gels. Available materials. The gel preparation is easier to apply than sprays and can be more easily localized. Sprays can affect unwanted areas in the mouth, and because the taste may not be well tolerated by the patient, it should be sprayed onto cotton wool before placing in the mouth. Benzocaine gel is flavored with attractive tastes, such as bubble gum or another variety of tastes, and that's why it is popular. And here you have a photo of these materials. Topex brand name, it is topical anesthetic gel, 20% of benzocaine as active ingredient in it. Lidocaine spray, 10%, and lidocaine 4% topical anesthetic available in cream. Mechanism of action. Topical anesthetics reversibly block nerve conduction near their site of administration by targeting free nerve endings in the dermis or mucosa, thereby producing temporary loss of sensation in a limited area. Nerve impulse conduction is blocked by decreasing nerve cell membrane permeability to sodium ions, possibly by competing with calcium binding sites that control sodium permeability. This change in permeability decreases depolarization and increases excitability threshold until the ability to generate an action potential is lost. Technique of application of topical anesthesia. The mucosa should be dried, and topical agents left in contact with the tissue for a period of time as indicated by the manufacturer's instructions. Adequate time, approximately 2-3 minutes, should be followed for the topical analgesic to take effect before starting an infiltration or regional block analgesia. The topical analgesic should be applied to as small as possible area. This reduces potential toxicity and prevents excessive numbness in the tongue and soft palate, which may be unpleasant for the patient. They are less effective on palatal mucosa and attached gingiva as they penetrate keratinized mucosa poorly. And here you have this photo that shows places for infiltration anesthesia. That's why to this area mucobuccal fold is applied topical gel on a cotton swab. And incisive anesthesia, that's why incisive or infiltration anesthesia from the palatal side, that's why to this area of injection is applied anesthetic gel, topical gel. Another type of anesthesia is infiltration analgesia. Supraperiosteal injection, it is synonym, and we call it widely infiltration, but the same meaning, supraperiosteal injection. This is the most common technique used for obtaining pulpal anesthesia and is more commonly known as local infiltration technique. This is a very easy technique and has a high success rate, but when several teeth require anesthesia, there is an infection or acute inflammation in the area of the injection. Regional nerve blocks are preferred. So such sites for infiltration analgesia and technique. So the syringe should be held parallel to the long axis of the tooth and inserted at the height of the mucobuccal fold over the tooth. Local infiltration in the oral cavity looks like on this photo. The area of treatment actually should be fluided with local anesthetic. And generally, the site for injection is mucobuccal fold. But needle should be positioned in such a way that bone tissue is touched and the site for injection is apexes of roots, because liquid should be, the anesthetic liquid should be positioned, deposited in that area, closely to the apical foramens. Mechanism of action. The agent is deposited beneath the epithelium, but above the periosteum within the mucosa. The analgesic is deposited around the terminal nerve endings and is therefore effective in a given site regardless of the source of innervation. Infiltration anesthesia is achieved when solution is deposited supraperiostally at the buccal side of the alveolar bone. The disadvantages of this technique are: it is only effective in obtaining pulpal anesthesia when diffusion through cortical bone occurs. Localized infection may be spread if an inflamed area is infiltrated. Only a limited zone of anesthesia per injection. Technique. In the maxilla, the cortical bone is thinner than in the mandible, and simple buccal infiltration can deliver pulpal analgesia. In the mandible, with the exception of the incisor teeth, because they get supply from the contralateral inferior dental nerve, the thick cortical layer of bone is present, and this actually prevents the use of infiltration technique for molar analgesia in the adult dentition. In this technique, the patient is asked to partially open his mouth, and the syringe is held parallel to the long axis of the tooth. The needle is inserted in the mucobuccal fold above the apex of the tooth and advanced until it touches the bone, then withdrawn a little, and the solution is deposited at a rate of 3 seconds per milliliter. If the solution is deposited while the needle touches the bone, the solution is injected below the periosteum, which is more painful and may cause post-injection discomfort. In general, the technique takes approximately 2 minutes before analgesia is achieved. And pulpal analgesia for maxillary teeth lasts for 45 minutes. Usually it is enough for endodontic treatment. Another type of anesthesia we discuss today, it is regional block analgesia. The regional block applications in the mandible include inferior alveolar and lingual nerve block, incisive and mental nerve block, long buccal nerve block, mylohyoid nerve block. At this photo, inferior alveolar nerve block is shown. The delivery of regional block analgesia in the maxilla is not permitted by the dental hygienist or dental therapist. It is necessary to keep in mind. The technique which deposits analgesic at the nerve trunk poses an increased risk of direct trauma to the nerve, hemorrhage, and intravascular injection of solution. So, maxillary regional block analgesia can be done by specially trained surgeon dentist. And actually, it is not need to be done if it goes about endodontic treatment. Regional block anesthesia may be used in the maxilla if infiltration methods are ineffective or to avoid multiple injections when a large area of anesthesia is needed. Regional block methods in the mandible will produce a widespread area of analgesia from a single injection and have an advantage that the delivery of analgesic is at sites discrete from local areas of infection. Inferior alveolar nerve block. The area of anesthesia. This traditional mandibular nerve block provides when successful pulpal anesthesia of all mandibular teeth in the quadrant, along with the buccal soft tissues and bone anterior to the mental foramen and the lingual soft tissues and anterior to sets of the tongue. And actually, here it is shown what is anesthetized by inferior alveolar nerve block. All that is green. If necessary to anesthetize buccal mucosa, it is recommended to do extra buccal block. But for endodontic treatment in dental therapy, it is enough to provide inferior alveolar nerve block because this is the area of anesthesia, and it is shown in green. Mechanism of analgesia of inferior alveolar nerve block. The technique aims to deposit a local analgesic solution in close proximity to the mandibular foramen on the medial aspect of the mandibular ramus. Actually, here it should be deposited anesthetic solution. The analgesic solution thus blocks nerve conduction where the nerve is accessible before it enters the inferior alveolar canal. By the way, here you can see mandibular division and three nerves: buccal nerve, inferior alveolar nerve, and lingual nerve. And here you have a subdivision of inferior alveolar nerve, mental nerve, that comes on a ramus of mandible through foramen mental. Technique. We have direct technique. It uses simple anatomical landmarks to assist the operator in locating the mandibular foramen. The patient's mouth is opened wide and the ramus is held with a thumb, as in this case, on the retromolar area in the coronoid notch of the ascending ramus. The thumb palpates the internal oblique ridge of the mandible and stretches the overlying mucosa, thus facilitating easy needle penetration. The index finger is placed exteriorly on the posterior aspect of the ramus at the same height as the thumb. In the adult, the mandibular foramen is halfway between the operator's thumb and index finger. The syringe is placed across the premolars of the opposite side of the mouth and directed between the external oblique ridge and the pterygomandibular ruff. This technique is not always successful. Failure may be due to faulty technique, anatomical variation in the location of the mandibular foramen, bending of the needle, or accessory nerve supplies. Regional block analgesia has the following disadvantages. The technique is more difficult than infiltration. Midline crossover of nerve supply is not managed. Patients dislike the excessively wide distribution of soft tissue analgesia. Deep tissue hemorrhage can cause infection and trismus. Although rare, direct nerve injury may occur. That possibly can lead to paralysis and other side effects that usually occur after injury of nerves. Another anesthesia that can be used in dental therapy, it is torus anesthesia. Torus anesthesia or Weisbrand anesthesia affects the entire area of the lower jaw, including the mucous membranes, teeth, cheek, chin area, two-thirds of the tongue, tip, and alveolar process. Torusal anesthesia is a modified inferior alveolar block. This method differs from the traditional one in that the doctor inserts a needle directly without any changes in inclination. As well, it is called go-gates block. Actually, you can find such name in English books, go-gates block, and it will be torus anesthesia, as we call it in our country. So go-gates block, another name. It is a variation of the inferior alveolar nerve block. It anesthetizes the following nerve: inferior alveolar nerve and its branches, mental and incisive nerve, mylohyoid nerve, lingual nerve, long buccal nerve, auriculotemporal nerve. Areas of anesthesia: all mandibular teeth, inferior alveolar nerve, epithelium of the anterior two-thirds of the tongue, lingual nerve, all lingual gingiva and lingual mucosa, lingual nerve, all buccal gingiva and mucosa, long buccal and mental nerves, skin of the lower lip, mental nerve, skin along the temple, anterior to the ear and posterior part of the cheek, auriculotemporal and buccal nerves. Technique. The mouth is opened as wide as possible. Insert the needle high into the mucosa at the level of the second maxillary molar, just distal to the mesiolingual cusp. Use the intertragic notch as an extraoral landmark to help reach the neck of the mandibular condyle. Advance the needle in a plane from the corner of the mouth to the intertragic notch from the contralateral premolars. This position varies in accordance with individual flare of the mandible until it contacts the condylar neck. Withdraw the needle slightly and perform aspiration to observe whether the needle is in a blood vessel. After a negative result on aspiration, slowly inject the anesthetic. Have the patient keep the mouth open for a few minutes after injection to allow the anesthetic to diffuse around the nerves. And here you have this photo, schematic representation of this technique. Patient is recommended to be in a laying position for better access of intertracheal notch. Actually, that is the point of injection. Of course, it is not the old techniques for anesthetizing, but it was the most used and advocated in dental therapy to manage pain during caries treatment or endodontic treatment. Other techniques as well exist, of course, but they mainly used in surgical department for teeth extraction, and they are not recommended to be done during, as I have said before, caries treatment or endodontic treatment. So this lecture is focused on that methods that primarily used in dental therapy department. The next chapter of the lecture is supplemental injection techniques. So, occasionally, traditional techniques of anesthesia like infiltration and regional block injections may not provide successful anesthesia, especially in endodontics for the so-called inflamed pulp or irreversible pulpitis. When inferior alveolar nerve block alone was used, only 1439% success rate was obtained, but when supplemental injections were included, success was significantly increased to 50-65% for irreversible pulpitis. The term intraligamentary or periodontal ligament anesthesia may be misleading, as the anesthetic injected into the periodontal ligament provides pulpal anesthesia by penetrating the cancellous bone through natural perforations. So here we have such supplemental techniques. Intraosseous injection is one of them. So intraosseous injection consists of introducing the local anesthetic directly into periradicular cancellous bone via specialized systems like StabiDent, Fairfax Dental, USA, and X-Tip Technologies, USA. This specially designed kit of instruments, needles of certain lengths, certain design that is placed on a syringe, and they are designed for intraosseous injection. And in this photo, you can visualize how it is done, how this needle penetrate into bone tissue. So technique for intraosseous anesthesia. In true intraosseous anesthesia, local anesthetic is injected directly into the bone surrounding the root of the tooth. Conceptually, the intraosseous injection is quite simple. The impediment of local anesthetic diffusion through bone in the adult mandible is the thickness of the cortical plate. Where a foramen is present, such as the mental foramen, the drug can gain access to the nerve and produce conduction blockade. Unfortunately, no such foramen is found on the buccal aspect of the mandible distal to the mental foramen, making it more difficult to obtain consistently reliable pulpal anesthesia on mandibular molars. In the intraosseous technique, a small perforation of foramen is made through the cortical plate of bone with a tiny dental burr, into which a needle then is inserted. And after that, local anesthetic is administered. Intraosseous injections can provide anesthesia of but a single tooth or multiple teeth in a quadrant, depending on the site of injection and the volume of anesthetic administered. When treating one or two teeth, 0.45 to 0.6 milliliters is usually used. Intraosseous anesthesia has proved to be of great benefit in endodontics when traditional injection has failed. And actually, this is armamentarium for intraosseous injection. Slow speed handpiece with a specialized needle, specialized burr that is used to make a hole in the bone, and a specially designed needle for intraosseous injection that is fixed on a carpal syringe. Another supplemental technique that can be used together with main techniques, it is intraligament injection. When pulpal anesthesia of a single tooth is required, the periodontal ligament injection should be considered. This is of special importance in the mandible, where nerve block anesthesia is the norm. In the maxilla, supraperiosteal injection infiltrated above the apex of any tooth will provide successful pulpal anesthesia with a success rate of more than 95%. Because of the thickness of the mandibular cortical plate of bone in adults, infiltration techniques are doomed to failure. They will be not successful. Therefore, although the periodontal ligament may be successfully administered to any tooth, its use is most often reserved for mandibular teeth, specifically mandibular molars. Disadvantages of such technique. The technique produces bacteremia and poses an increased risk of systemic effects. There is a risk of inducing periodontal damage or infection resulting in pain following injection. Also contraindicated in the presence of active periodontal disease. The technique can be used to avoid the need for inferior dental block in children and to treat patients with bleeding disorders without the need for provision of blood clotting factors. Intrapulpal anesthesia. In approximately 5–10% of mandibular posterior teeth with irreversible pulpitis, supplemental injections, even when repeated, do not produce profound anesthesia. Pain persists when the pulp is entered. This is an indication for intrapulpal injection. So, with the increased interest in the very successful intraosseous technique, however, the need for intrapulpal anesthesia should reduce. Another chapter of lecture that deals with armamentarium that is used for local anesthesia. So the general constituents of a dental cartridge of anesthetic solution are local anesthetic agent, vasoconstrictor. It is sometimes included to delay the removal of the anesthetic from the tissues by decreasing the blood flow through adjacent blood vessels. A vasoconstrictor produces the following advantages: longer duration of local anesthetic action, reduced bleeding of a surgical site, and reduced systemic effects. The most commonly used vasoconstrictors are epinephrine, adrenaline, and octapressin or felipressin. Only epinephrine is available in the United States. It should be kept in mind. A reducing agent, another compound that is present in carpule. This prevents oxidation of the vasoconstrictor and acts by competing with the vasoconstrictor for oxygen available in the solution. The most commonly used reducing agent is sodium metabisulfite. Preservative, a bacteriostatic preservative prolongs the shelf life of the solution, but since preservatives can provoke allergic reactions, they are no longer contained in dental local anesthetic cartridges in the United States. The typical shelf life of an anesthetic without preservative is approximately 18 months to 2 years. Fungicide. Thymol is used occasionally as a fungicide. Carrier solution. It is an acidic aqueous solution that dissolves the local anesthetic salt and maintains it at an acceptable pH. By the way, here you have the cartridge with lidocaine hydrochloride 2% with epinephrine in solution, in dilution actually 100,000 units. And pay attention on the cartridge as well is given information about the amount of solution in this carpule. It is 1.7 milliliter. The mechanism of action of local analgesic agents. The other factor which determines efficacy of individual local analgesic agents is their effect on blood vessels. Those with a more effective vasoconstrictor property are retained at higher concentration for a longer period of time in the tissues. Hence, they provide better depth and duration of analgesia. The addition of a vasoconstrictor such as adrenaline, epinephrine reduces local blood flow, slows down the rate of absorption of the local analgesic, and thus prolongs the duration of analgesia. In dental formulations up to 1 in 80,000 adrenaline, 12.5 milligram per liter, is used in local analgesic solutions. Lidocaine 2% or articaine 4%, it is the most commonly is the most widely used active ingredients of anesthetic solutions, lidocaine 2% or articaine 4%, with 1 in 80,000 adrenaline is a safe and effective formulation that has been used for routine dentistry for many years. In patients with severe hypertension or unstable cardiac rhythm, the use of adrenaline in local analgesic solution is hazardous. In such patients, it is usual to use prilocaine with or without vagipressine, a vasoconstrictor related to octapressine. Both mepivacaine and articaine are available with and without adrenaline in their formulation. Instruments that are used in dental local analgesia. Syringes, along with attached needles and analgesic cartridges, are required for conventional delivery of local analgesic with simple hand pressure. Computerized delivery systems have a pump to control the pressure and hence the rate of injection. The majority of commonly used dental local anesthetics fall into the amide category. Lidocaine, mepivacaine, bupivacaine, prilocaine. Though there are some amide-type local anesthetics that also contain an additional ester linkage, articaine. So these are the mainly used active ingredients in anesthetic solutions. And structure of anesthetic syringe. So here we have anesthetic syringe. It has such parts: thumb ring, finger grip, piston with harpoon where carpule is placed, syringe barrel, actually this is the place where carpule is put, and needle adapter to which the needle should be connected. So local anesthetic syringe is used to administer local anesthetic with a disposable anesthetic cartridge and a disposable needle. The finger bar of the syringe control the piston rods. Which depresses the rubber stopper of the anesthetic cartridge during aspiration. When the piston rod is depressed, the local anesthetic solution is forced out through the disposable needle, which is screwed onto the threaded tip. The barrel of the syringe is open on both sides to facilitate loading the anesthetic cartridge and check for blood cells during aspiration. Disposable needle. We have such parts of it: cartridge penetration and actually needle. Needle has hub, shaft, and bevel. and syringe adapter. And pay attention to the different lengths. It is available in few possible lengths: Lone and standard. A disposable needle is threaded onto the hub of a syringe. The short end of needle punctures the rubber diaphragm of the cartridge. It is single use. It is disposed in a Sharps container. Prior to use, check seal if it is intact, expire date, and the length and gauge of the needle. Lumen is the hollow center of the needle. Gauge is the thickness of the needle. The type of injection dictates the appropriate length and gauge of the needle to be used. And cartridge. Glass, disposable, local anesthetic cartridge. On the cartridge, the dentist can obtain such information. Drug, identifying color-coded band, actually the name of drug. It can be articaine, xylocaine, and percentage of the solution. And of course, vasoconstrictor that is used. If it is used, it should be indicated here, and the dilution as well should be indicated. If it is without vasoconstrictor, here should be indicated no vasoconstrictor. Date, expire date, and serial number of manufacturer, and amount of anesthetic liquid, 1.8 milliliter in this case. So it is that what is written, and now what is located on the cartridge. So plunger, indented from rim of glass, silicone rubber plunger, neck, aluminium cap, and rubber diaphragm into which the needle is screwed, threaded into. So this contains local anesthetic solution for delivery. Prior to use, check expiry date. Cartridge and rubber diaphragm should be intact, and the color of the local anesthetic solution as well should be clean without any plates. It is single-use item, disposed in the Sharps container, contains water, preservatives, anesthetic solution, and buffering agents. Some can contain vasoconstrictors. And final chapter of this lecture is complications and emergencies which can be associated with local analgesia. So, despite the recognition that local analgesia has a safe record in dental applications, it is important to be familiar with potential complications. At greatest risk of complication from use of local analgesia are children, the elderly, and the medically compromised. It is vital to obtain a careful medical history, including analgesic history, before delivering local analgesic, since allergy, toxicity, and drug interactions account for the most serious complications. Complications of local anesthetic administration include both local effects and systemic effects. So, local complications include spread of infection. Occasionally, infection may be spread into the tissues by the needle passing through a contaminated tissue or by the needle being contaminated before use. Hematoma. Damage of blood vessel by the tip of a needle may lead to bleeding into the tissues, resulting in the formation of a hematoma. Significant bleeding may produce swelling, act as an irritant to the tissues, and cause pain and trismus. Theoretically, the localized collection of blood becomes an ideal culture medium for bacteria, although infection of a hematoma is unusual. Another complication, nerve damage. Rarely. During an injection, the needle may pierce a nerve bundle during placement, producing an immediate electric shock sensation to the patient. It is usually followed by a partial sensory deficit, but subsequently a complete return to normal sensation usually follows. Blockade of the fascial nerve. If the injection is given in close proximity to the fascial nerve, a motor blockade causing temporary paralysis of the muscles of facial expression may occur. The effect may last for 1–2 hours. In such circumstances, the desired branch of the trigeminal nerve will not be anesthetized, and a subsequent injection will be required at the correct anatomic location to achieve the desired effect. Systemic complications include regional or systemic infection. The spread of infection within the perioral tissues can be potentially spread through planes of the head and neck by passage of a needle through an infected area. Endocarditis risk. Injections such as the intraligamentary injection can force bacteria into the systemic circulation and cause bacterial endocarditis. Cardiovascular disease. Patients with ischemic heart disease, angina pectoris, previous myocardial infarction, or those who have had previous cardiac surgery or circulatory dysfunction, such as a cardiac failure, show higher plasma levels of lidocaine when compared with healthy subjects given the same dose. Therefore, it is recommended that the maximum safe dose be halved in such patients. Low plasma potassium levels and acidosis also potentiate adverse effects of local anesthetics on the myocardium. Liver disease. Patients with reduced hepatic function may exhibit an abnormally decreased rate of metabolism of amid local anesthetics, resulting in potentially toxic blood levels. Dosage levels must therefore be reduced for these patients. So here I have grouped the most common complications during local anesthesia delivering. And they are such: trauma, failure to achieve analgesia, fainting. So trauma. The delivery of rapid injection or poor technique can result in direct nerve damage or hematoma formation. This can lead to pain and patient anxiety. Pain at the time of injection can be avoided by careful technique, including the use of a slow injection of isotonic solution. After pain results from direct tissue trauma, resulting in hematoma, infection, or trismus. Failure to achieve analgesia. Patient anxiety may lead not only to fainting, but also to a reduced analgesic efficacy. In such cases, it may be necessary to consider the use of conscious sedation to reduce anxiety. Inflammation in the site of infection will prevent adequate analgesia. In such circumstances, use of regional block may be more successful. Anatomical variation in relation to bone architecture and nerve supply also accounts for failure to achieve analgesia. And fainting, or loss of consciousness, or syncope, all of these are synonyms. So fainting may occur before, during, or after the administration of local analgesic. Typically, the patient will become pale, sweaty, and complain of nausea. Some patients describe a tingling sensation in the hands and feet prior to loss of consciousness. The pulse is first rapid, then becomes slow and weak. Fainting can be avoided by dealing with the patient in a calm, reassuring, and confident manner. The delivery of local analgesia should always take place with the patient in a supine position. In the event of faint, lay the dental chair flat to ensure a supply of blood to the brain. The patient should recover spontaneously and treatment can then continue. And in a conclusion, we can come to such statements. So, clinically effective pain control can be achieved in the vast majority of patients, requiring endodontic therapy using different techniques dependent from the case. When problems achieving pain control occur, it is usually at the initial visit, when a frightened patient who has been heartened for some period of time finally seeks relief from pain, yet oftentimes is unable to manage the fears of dentistry. Through a combination of thoughtful caring for the patient, the use of conscious sedation when indicated, and the effective administration of local anesthesia, endodontic treatment can proceed in a more relaxed and pleasant environment for both patient, and dental staff. So these are such statements that can be used as a conclusion to this lecture. References that can be considered as well as a further reading as such. Ingalls endodontics, successful local anesthesia for restorative dentistry and endodontics, and of course, to refresh knowledge about anatomy of nerve supply to the facial-maxillary area, I recommend to read Netter's Head and Neck Anatomy for Dentistry. Okay, thank you for attention.